You brush, you floss, you chew a mint, and the breath is still there. What if the culprit isn't your mouth at all, but your stomach? That idea sounds surprising, even embarrassing, but it's real. In some people, reflux and other digestive issues can change the smell coming from your mouth. If mints only mask it and not fix it, this video will walk you through the signs that point toward a stomach origin, the quick checks you can do right now in good light, and a focused 48-hour routine to help you and your clinician figure out what's going on. Before we start, one quick favor. If you want the hands-on demo showing how to perform the test safely, subscribe now so you don't miss it. I'll show step-by-step technique in that follow-up video. Let's get grounded in why this happens. The mouth is an ecosystem, a warm, moist space full of bacteria that feed on food debris, dead cells, and secretions. When these bacteria break down substrates like proteins, they release volatile sulfur compounds, or VSCs, molecules that smell like rotten eggs or sulfur. Those are the classic oral smells. But breath can carry other chemical signatures too. Fruity or acetone-like odors often come from ketones in fasting or diabetes. An ammonia or urinous smell can suggest kidney dysfunction, and a sour or acidic odor, often described as metallic, vinegary, or tangy, can be a sign that stomach acid or gastric contents have reached the throat and mouth. Reflux doesn't always look like heartburn. When it reaches the laryngopharynx, it can cause more subtle symptoms and produce a different smell profile. The reality is most chronic bad breath starts in the mouth. The tongue's back surface, periodontal pockets, plaque around failing restorations, and trapped debris in devices like dentures. ENT issues, chronic sinusitis, postnasal drip, and tonsil crypts are another common set of contributors. Stomach or systemic causes are less common, but they're important to consider when the clinical picture suggests them. The goal here is practical. Give you simple, safe checks to narrow the likely source, a short, targeted routine you can try while you track results, and guidance on when to see a dentist, ENT, PCP, or gastroenterologist. 3 quick checks you can do in a well-lit bathroom. Do these in order and make notes. Be gentle and stop if anything causes pain, gagging, or bleeding. First, the tongue scrape smell test. Lean slightly forward over a sink, stick out your tongue as far as comfortable, and use a tongue scraper or the clean edge of a spoon to gently scrape the middle to back surface of the tongue once or twice. Wipe the scrapings onto a small piece of tissue or smell the scraper itself from a short distance. If the odor is immediately sulfurous or strongly foul, that points strongly to tongue coating, a bacterial reservoir on the posterior tongue, as a major contributor. Perform a warm saline gargle. Dissolve half a teaspoon of salt in an 8-ounce glass of warm, comfortable water and gargle for 10 to 15 seconds, then spit. This helps clear superficial secretions without long-term microbiome disruption. Do this only if it's comfortable. Daytime and after meals. After meals, mechanically remove food debris. Floss, and if you chew gum, choose a xylitol gum, sugar-free, for occasional use to stimulate saliva and clear food. Saliva helps neutralize acids and wash away food particles, reducing substrate for bacteria. Stay hydrated. Small sips of water throughout the day help reduce oral dryness, which worsens odor. Evening. Repeat tongue scraping and gentle warm saline gargle before bed. Floss and brush as usual. If postnasal drip is present, consider gentle nasal saline irrigation once daily, only if you are comfortable with the technique and have no contraindications, to reduce mucus pooling that can feed malodorous bacteria. Additional cautions and limits for the 48-hour trial. Use an alcohol-free mouthwash for short periods if desired, but avoid prolonged use of strong antiseptics without clinician supervision. Don't stop prescribed medications. Note medications in your log so the clinician can review them. If you experience bleeding, severe pain, or any worrying systemic symptoms, stop and seek care promptly. How to track change. The goal of the 48-hour trial is to see measurable improvement in your morning smell score and symptom notes. If you get clear improvement, that suggests a reversible, often local contributor. If there's no change, or if the odor shifts in quality, for example from sulfurous to sour or acidic, that pattern will guide further testing and referral. Understanding the main oral reservoirs and what to expect. Tongue coating. The back of the tongue is a major reservoir because of deep grooves, reduced mechanical cleaning by the tongue itself during sleep, and limited airflow that favors anaerobic bacteria. A thick whitish or brown coating often suggests bacterial and cellular debris accumulation. When tongue coating is the main source, consistent mechanical cleaning, scraping or brushing the tongue, twice daily often reduces odor within days, though more entrenched coatings may take longer. Antimicrobial rinses can be helpful short-term, but they're not a long-term fix without addressing the mechanical reservoir. Periodontal pockets and gum disease. Periodontal gum disease creates deeper pockets between tooth and gum where anaerobic bacteria flourish. These pockets can produce strong, putrid odors that do not respond well to simple rinsing or tongue scraping. Signs pointing to gum disease include bleeding on flossing, gum recession, persistent bad taste, loose teeth, and a foul smell localized to an area of the mouth on gauze floss testing.
Treatment requires a dental evaluation and professional cleaning. Improvement is typically measured over weeks to months after therapy and improved at-home hygiene. Restorations and trapped debris. Old fillings, crowns with gaps, and poorly fitting appliances can trap food and bacteria. If your floss or gauze test localizes the smell to a specific tooth, or if you notice persistent bad taste near a restoration, mention this to your dentist. Repair or replacement of marginally failing restorations often resolves the localized odor once the bacterial source is removed and the area is cleaned. Tonsil crypts and tonsilliths. Tonsil stones form when debris collects in the crevices of the tonsils and calcifies. They often cause an intermittent bad taste and can be visible as small white or yellowish spots. Small stones may be managed conservatively with gentle saltwater gargles and increased oral hygiene, but avoid aggressive home removal. Using fingers, cotton swabs, or sharp objects risks bleeding and infection. Recurrent, large, or symptomatic stones are best managed by an ENT, who can discuss professional removal techniques or, in select cases, definitive options. ENT and sinus contributors, when to consider them now. If you have chronic nasal congestion, frequent post-nasal drip, a constant bad taste even when your oral cavity checks are negative, or if the smell seems to be coming from the throat rather than the teeth or tongue, ENT causes deserve attention. Post-nasal drip carries mucus and bacteria down the throat where they contribute to odor, and chronic sinusitis can be a persistent reservoir. An ENT evaluation may include nasal endoscopy or imaging to look for chronic sinus disease, large tonsil crypts, or anatomical issues that retain secretions. If your symptom log shows clear throat mucus, worse smell in the morning with nasal congestion, or improvement after saline nasal rinse, ENT referral is reasonable. Now, guided by the title of this video, let's focus on the stomach and reflux, how gastric contents can reach the throat, how that alters smell, and what specific signs make a stomach origin more likely. Why and how the stomach can affect breath. When gastric contents, acid, enzymes, or small amounts of food travel upward into the esophagus and reach the larynx and pharynx, they can change the local environment and leave odorous molecules. Two overlapping clinical pictures are relevant. Gastroesophageal reflux disease, GERD, which typically involves heartburn and acid regurgitation, and laryngopharyngeal reflux, which often presents without classic heartburn but with throat symptoms. LPR can deposit acidic or non-acid gastric refluxate around the vocal cords and back of the throat, producing a sour or acidic smell and taste and causing throat irritation. Smell and taste signatures that suggest a gastric contribution include a persistent sour or metallic taste, frequent acidic burps or regurgitation, an overnight or morning worsening, especially if you sleep flat or lie down soon after meals, and associated throat symptoms, chronic cough, throat clearing, hoarseness, or a sensation of a lump in the throat. Importantly, a stomach cause is more likely when oral and ENT checks are unrevealing, neutral tongue scrape and gauze tests, clear tonsils, and absence of periodontal disease signs. Only with that constellation of findings, negative oral and ENT tests plus reflux-type symptoms, should stomach causes move up the differential. Differentiating GERD and LPR in plain language. GERD usually feels like heartburn, a burning behind the breastbone, and often includes visible regurgitation of sour material. LPR may lack heartburn. Instead, you may have throat clearing, a chronic dry cough, hoarseness, or chronic throat discomfort without classic reflux sensations. LPR is sneaky. It can irritate the larynx and pharynx and change breath without dramatic chest symptoms. Because of that, patients with LPR sometimes spend a long time being treated for oral or ENT causes before reflux is considered. Cautions about attribution. It's important to emphasize, even if reflux is present, it may not be the sole cause of halitosis. Many patients have mixed causes. We prioritize the stomach in this video because the title raises that possibility. But statistically, oral causes remain the most common. That's why the stepwise approach, do the 3 checks, document, try the 48-hour trial, then escalate to investigation if the pattern fits reflux, is useful. Introducing Jordan's case, a real-world example. Jordan is in his late 30s and works nights. He noticed a persistent sour taste in the morning and a distinct acidic breath that seemed worse on days he ate late. He didn't have obvious gum disease, his tongue scrape produced only a mild smell, and his gauze test was relatively neutral. His tonsils looked normal. He did have occasional heartburn, but had dismissed it as just indigestion. Over several weeks, his morning cough became more noticeable, and coworkers began commenting on a lingering sour smell. Jordan began the 48-hour targeted routine while keeping a log. He recorded morning smell scores, what he ate late at night, and whether he woke with regurgitation or a sour taste. He also noted positional patterns. His symptoms were worse when he lay flat after eating. After 48 hours, there was no meaningful improvement in his morning smell score. In fact, nights with late meals and alcohol correlated with worse scores. His tongue and gum checks remained unrevealing. These patterns shifted the suspicion toward a reflux-related source and prompted him to schedule an appointment with his primary care clinician to discuss reflux and whether gastroenterology referral was appropriate.
What Jordan's pattern illustrates is how documentation helps clinicians. The simple log gave objective patterns, correlation with late meals and positional worsening, lack of oral NT findings, and a sour smell signature that justified further evaluation for reflux. It did not, by itself, prove that the stomach was the cause, but it made reflux a plausible, testable hypothesis. What clinicians may consider when reflux is suspected. If reflux becomes reasonable to suspect, a clinician will start with careful history and physical exam and may recommend conservative measures first. Lifestyle changes, avoiding late meals, reducing trigger foods, elevating the head of the bed, a trial of reflux hygiene, and documentation of symptom changes over a 2-week period. Diagnostic testing, such as pH monitoring or endoscopy, may be considered when symptoms are severe, refractory to conservative measures, or when alarm features are present. These are decisions for clinicians, made case by case. Safe initial steps you can take and document before seeing a clinician. If your pattern suggests reflux, try simple reflux hygiene while you keep your log. Avoid large late meals, reduce alcohol and known dietary triggers, and avoid lying flat for 2 to 3 hours after eating. Elevating the head of the bed a few inches can reduce nocturnal reflux in some people. Do not start or stop prescription medications on your own. Instead, document your symptoms and bring the log to your clinician visit. When you do see your clinician, the notes you bring, dates, smell scores, positional patterns, related symptoms, make it much faster for them to decide next steps. Where we are now, connecting the dots and preparing to act. By now, you've learned the 3 quick self-checks that narrow the likely source of bad breath. You've got a specific 48-hour routine you can try, and you understand how oral reservoirs differ from ENT and stomach causes in smell character and expected timelines. You've also seen how a focused log can turn subjective embarrassment into objective data that your clinician can use. In Jordan's case, the 48-hour trial and his notes moved reflux from a vague suspicion to a clinically relevant possibility that justified a next-step discussion with his PCP and potentially gastroenterology. What comes next is the practical triage. When to prioritize a dentist or periodontist, when ENT is the right next step, and when to ask your PCP about GI evaluation. We'll cover short, clinician-ready scripts you can use at your appointments, a 2-week extended plan to give more robust data, the red flags that require urgent attention, and safe approaches to manage tonsil stones at home versus when to seek professional removal. We'll also dig deeper into diagnostic nuances of LPR and what kinds of tests clinicians may consider if conservative measures don't help.
Before we move forward, a quick recap to keep in your pocket. Perform the 3 checks in good light, keep a symptom and smell log, try the 48-hour targeted routine, and note whether the odor quality is sulfurous, fruity, sour, or urinous. Those signatures matter. If tongue scraping clears things up, stay consistent with mechanical cleaning. If gauze, floss points to a localized dental problem, see a dentist. If the tonsils show stones or chronic crypts, an ENT should evaluate. If none of those explain the odor, and you have reflux-type symptoms, sour taste, regurgitation, nocturnal worsening, hoarseness, or chronic cough, then the stomach may be playing a role, and your documented log will be the most useful tool you bring to the clinician conversation. At this point, consider whether your 48-hour log is giving you a pattern. If you've completed it and still feel stuck, it may be time to expand to a 2-week plan with the same fields in your journal, adding notes about sleep position, late meals, alcohol intake, and any medication changes. That longer window often reveals patterns that 2 days might miss, especially for reflux that varies with diet and sleep. In the next section, we'll walk through the 2-week plan, the clinician scripts for dentist, ENT, PCP, and GI, and specific red flags that need urgent evaluation. We'll also return to Jordan's story and follow his next steps with his clinician to see whether reflux truly was the primary driver of his breath problem and how his care team approached testing and treatment options. If you've completed the 48-hour trial and you're still puzzling over the cause, extending the observation window to 2 weeks often makes the difference. A longer log reduces day-to-day noise and reveals patterns tied to diet, sleep, medications, and environment. For the next 14 days, keep the same fields you used in the short trial, but add a few more columns: sleep position, e.g. propped or flat, time of last meal before bed, alcohol or caffeine after dinner, and any episodes of perceived regurgitation or nocturnal cough. Include a simple morning smell rating from 1 to 10, a short note about the odor quality, sulfurous, acid sour, fruity, urinous, or mixed, and whether your tongue scraping or gauze test changed that day. If you can, take a phone photo of visible tonsil deposits or a clear image of any suspect dental restoration. Time-stamped photos are especially helpful for clinicians. Even if pictures feel embarrassing, they convert subjective impressions into objective evidence that speeds decision-making at appointments. As you log, try to keep some consistency in your routine so you can see the effects of behavior change. For example, if you normally eat late, pick 3 consecutive nights where you avoid late meals and compare the morning smell scores. If you think alcohol or a particular late-night snack is a trigger, deliberately skip it for several nights and note the result.
If you suspect positional worsening, prop up the head of your bed a few inches for 5 nights and write down whether mornings improve. These interventions are about gathering diagnostic information rather than guaranteeing resolution. Consider them trials to test hypotheses before you consult a clinician. While you run the 2-week plan, it helps to know what to expect for different causes so you can interpret the timetable. If the posterior tongue is the main reservoir, you may notice a measurable drop in odor within a few days of consistent scraping twice daily and proper hydration. Those stubborn coatings sometimes take several weeks to thin out. If periodontal disease or a failing restoration is the driver, improvements after professional care are typically measured in weeks to months and require follow-up cleanings and maintenance. For sinus or post-nasal drip contributors, conservative measures like daily saline nasal irrigation and nasal steroid sprays, when already prescribed or suggested by an ENT, can reduce mucus pooling over days to a few weeks. Chronic sinus disease may need a longer course of treatment or procedural intervention to fully clear. For reflux-related contributors, lifestyle measures and hygiene can reduce symptoms in a matter of days for some people. But meaningful change in breath quality often takes several weeks and sometimes requires medical therapy or further testing. If, after 2 weeks, a clear pattern emerges, oral tests are negative, you consistently score worse after late meals or lying flat, you have a persistent acidic taste, hoarseness, or chronic cough, then present your findings to the appropriate clinician. Below are concise, clinician-ready scripts you can use to make the visit efficient and focused. These scripts are designed to be factual, timeline-oriented, and to request reasonable next steps without demanding or prescribing specific tests. When you see your dentist, say, "Over the past 2 weeks, I've kept a daily log of my morning breath and oral checks. My tongue scraping test has been neutral most mornings, my gauze/floss test localized no foul odor, but I continue to have a persistent morning odor and a sour taste. I've noted occasional bleeding on flossing in this area, specify tooth number or side, and I'd like a full periodontal evaluation, bite and restoration check, and any necessary radiographs or hygiene therapy to rule out a dental source. If you have photos, show the time-stamped image of the area that concerns you. Ask what the expected timeline for improvement would be after professional cleaning or restoration repair, and request a follow-up plan. When you see an ENT, say, "I've completed a 2-week smell log and home checks. My tongue and dental tests are unrevealing, but I have chronic throat clearing, intermittent hoarseness, and a persistent sour taste, worse in the mornings and after late meals. I also notice nocturnal cough and positional worsening when I sleep flat." Could an evaluation for laryngopharyngeal reflux or tonsillar crypts be appropriate? I'd like an assessment for postnasal drip and, if indicated, an endoscopic exam to look for laryngeal or nasal sources. Mention any visible tonsil stones with timestamps or photos and whether they're recurrent or symptomatic. When you visit your primary care clinician, say, "I've kept a 2-week log that links my bad breath and sour taste to late meals and positional changes at night. My home oral and ENT checks were not suggestive of a primary dental source. Could we review possible reflux or systemic contributors? I'd appreciate screening for diabetes or renal issues if you think it's warranted, and guidance on whether a referral to gastroenterology is appropriate. Be explicit about medication lists. Here are my medications. I want you to review whether any may be contributing to dry mouth or other symptoms, but I'm not stopping anything without your advice." When you meet with gastroenterology, typically after PCP referral, present the targeted story. "My primary care clinician referred me after a 2-week log showed positional and dietary triggers, worse mornings after late meals, acidic burps, and a persistent sour taste, while oral and ENT evaluations did not identify a clear source. I'd like an assessment for reflux or LPR and to discuss diagnostic options and treatment pathways. My log shows the dates and symptom severity. Ask about what conservative measures to try first and which tests would be considered if symptoms don't respond." Those scripts help clinicians triage efficiently. In practice, many cases are solved by a combination of measures across disciplines: a dental cleaning and repair of a leaking restoration, a short course of targeted ENT therapy for postnasal drip, and reflux hygiene measures implemented alongside primary care monitoring. Because halitosis is often multifactorial, teamwork between providers sometimes yields the best outcome. It's also important to be aware of systemic and medication-related contributors so you can mention them in appointments. When breath has a fruity or acetone-like character, especially if you have polyuria, unexplained thirst or fatigue, diabetes or ketosis should be considered. A urine or blood glucose check through your PCP is a reasonable next step. When breath has an ammonia or urinous smell and you have edema, decreased urine output, or unexplained fatigue, evaluation of kidney function is warranted. Liver disease can also alter breath quality in advanced cases, with particular systemic signs that your PCP can screen for. Many commonly used medications cause dry mouth, which amplifies oral odor by reducing saliva's cleansing effect. Antihistamines, some antidepressants, certain blood pressure medications, and some anticholinergic agents are frequent offenders. Don't stop any medication on your own. Instead, document the time relation between dose and symptoms and ask your clinician to review alternatives if they think drug-induced dry mouth is contributing. Safe home care for tonsil stones and limits of self-removal deserve special attention. Small, occasional tonsil stones that are visible and not painful may respond to conservative measures: gentle saltwater gargles, improved oral hygiene, and non-invasive irrigation with a clinician-recommended device if you are comfortable using one. If you try to dislodge a stone yourself, never use sharp instruments, fingernails, or force that risks bleeding. If a stone recurs frequently, causes pain, significant gagging, breathing difficulty, or bleeding, or if it's large and uncomfortable, see an ENT. Recurrent symptomatic tonsilloliths may be managed in clinic with appropriate instruments, or in select cases, definitive surgical options can be discussed with an ENT. These are decisions made together based on frequency, severity, and overall health priorities. When sinus disease or postnasal drip is suspected, initial at-home measures include daily nasal saline rinses and adherence to any nasal sprays already prescribed by your clinician. If you don't have an existing prescription, mention your symptoms to your PCP or ENT rather than starting prescription medications on your own. ENT evaluation can identify whether chronic sinusitis, allergic rhinitis, or anatomical factors are retaining mucus, and treatment options range from medical therapy to procedural interventions when warranted. If a clinician recommends imaging or nasal endoscopy, those are diagnostic tools to identify persistent reservoirs of infected mucus or structural contributors that mechanical or medical therapy alone will not resolve. Be aware of red flags that need prompt or urgent evaluation. Seek immediate care if you develop high fever with severe throat pain, sudden difficulty breathing, trouble swallowing, or a rapidly expanding swelling in the neck. If you experience blood in sputum or vomit, prolonged unexplained weight loss, or persistent progressive hoarseness accompanied by swallowing difficulty, bring these to a clinician as soon as possible. These are not common causes of bad breath, but they are important safety checks. Mention them candidly in your log and at your visit so clinicians can prioritize appropriate investigations without delay. To make the 2-week trial and subsequent visits as effective as possible, here are practical examples of what to document in your log. For each day, write the date. Upon waking, record a smell score 1 to 10 and a 1-word odor descriptor. Note whether you scraped your tongue and what the scrape smelled like. Record the gauze floss test result and any visible tonsil findings. List the time of your last meal and the main components, e.g., late pizza with garlic or light salad. Note whether you drank alcohol the night before, whether you slept propped, and whether you had any regurgitation, hoarseness, chronic cough, or nasal congestion that morning. In the notes section, include any medication taken the previous evening or over-the-counter drugs used, plus any dental or ENT symptoms like bleeding or localized tooth pain. This structured record turns subjective complaints into data. Now let's return to the short clinical vignettes we introduced earlier to illustrate how these pieces come together in real lives. First, Anna. Anna is in her late 20s and works long shifts in retail. She presented with persistent bad breath that she had been trying to manage with frequent mouthwash and mints. Her 48-hour log showed high morning smell scores that dropped noticeably on days she consistently scraped her tongue. Her gauze test was neutral and her tonsils were clear. After a focused discussion with her dentist, Anna committed to mechanical tongue hygiene twice daily, maintained hydration, and reduced alcohol consumption. Within a week, she reported a noticeable improvement in morning breath. By 3 weeks, her scores had dropped markedly. Her case underscores how a straightforward mechanical reservoir like posterior tongue coating can be a fast win when addressed consistently. Marcus is in his mid-40s and was the opposite pattern. He flossed intermittently but had a history of periodontal bleeding and an old crown that never felt quite right. His gauze floss test yielded a strongly putrid smell, and his dentist's periodontal probe found deep pockets in the upper molar region. Marcus underwent professional scaling and root planing and had his crown evaluated and replaced where necessary. His improvement was gradual, measured in weeks rather than days, but steady. Marcus's story demonstrates how dental disease often needs professional intervention and that resolving these causes improves breath over time when followed by consistent home care. Leah had a long history of nasal congestion and intermittent sinus pressure. Her smell log noted a persistent bad taste despite neutral tongue and floss checks, and she often woke with thick nasal mucus that she swallowed overnight. Her ENT performed an evaluation and found chronic sinus inflammation with areas prone to mucus retention. With guided medical management and adherence to saline irrigation, Leah's mucus burdens decreased and her morning breath improved over several weeks. Her case shows that non-oral reservoirs like sinuses can be stubborn but respond to appropriately targeted ENT care. Finally, Jordan's story continues from where it left off. After his initial 48-hour trial, Jordan extended to the 2-week plan and documented consistent correlations between late meals, lying flat, and worse morning smell. He brought his log and time-stamped photos to his PCP visit.
His PCP reviewed the pattern, confirmed there were no systemic red flags, and recommended conservative reflux hygiene while referring him to gastroenterology because of the positional component and ongoing cough. Jordan was advised to avoid large late meals, reduce alcohol intake, and elevate the head of his bed. He was not started or stopped on any medication without careful clinical oversight. Instead, his PCP used the log to triage the urgency of GI referral and to rule out systemic issues via routine labs. Jordan's GI consultation reviewed his history and log. The gastroenterologist emphasized that reflux and LPR can be subtle and are often diagnosed clinically, particularly when oral and NT evaluations are unrevealing and the symptom pattern matches reflux triggers. Given Jordan's persistent symptoms and their clear timing with late meals and lying flat, a stepwise approach was chosen: lifestyle and behavioral measures first, with monitoring and follow-up. Over the next 4 weeks, Jordan reported progressive reduction in morning sour taste and fewer acidic burps, and his morning smell scores decreased modestly. For Jordan, a combination of behavioral change and time improved the breath quality. In other cases, if symptoms had been refractory or alarm signs were present, additional diagnostic testing or targeted therapies might have been discussed with the GI team. Jordan's outcome highlights how documentation and measured trials can prevent unnecessary tests and focus care on likely contributors. Throughout all of these examples, one principle stands out: be methodical and collaborative. Halitosis rarely benefits from hurried, unilateral solutions. The most efficient path is to gather clear data, try safe, conservative interventions, and then present concise, evidence-based findings to the clinician best suited to address the suspected source. Dentist, periodontist for dental reservoirs, ENT for tonsil and sinus sources, PCP for systemic workup and medication review, and gastroenterology for suspected reflux or stomach contributions. If your symptoms persist despite well-documented 2-week trials and appropriate referrals, a coordinated approach is often necessary. Your dentist might perform a more thorough periodontal mapping and take radiographs. An ENT might perform flexible nasoendoscopy to visualize the larynx and posterior pharynx. A gastroenterologist may discuss targeted reflux testing or additional investigations as clinically indicated. These are clinician-led decisions. Your role is to provide the best possible history and documentation so the care team can choose the right next step efficiently. Before we close, here's a practical checklist you can screenshot or copy into your notes. Have you completed the 3 home checks in good light? Are your morning smell scores recorded daily for 2 weeks? Do you have time-stamped photos of any visible tonsil deposits or suspect dental areas?
Have you tracked timing of meals, alcohol, sleep position, and any reflux symptoms like regurgitation, sour taste, or nocturnal cough? Did you try the 48-hour targeted routine followed by a focused 2-week trial of reflux hygiene if appropriate? If the pattern points to dental issues, see a dentist or periodontist with your log. If tonsils or postnasal drip are implicated, schedule ENT evaluation. If systemic signs or a fruity, acetone, or ammonia quality is present, see your PCP for testing. If reflux-type patterns dominate with neutral oral ENT checks, bring your log to your PCP and request consideration for gastroenterology referral. A final practical note on common missteps: avoid excessive, repeated use of strong antiseptic mouthwashes as a long-term strategy. They can temporarily reduce odor, but may disrupt the oral microbiome and are best used short-term under clinician guidance. Do not attempt aggressive home removal of tonsil stones with sharp instruments. That risks bleeding and infection. Do not stop prescribed medications without discussing alternatives with your prescriber. And if you feel overwhelmed or uncertain about next steps, a single coordinated appointment where you bring your log and photos to your PCP can be the most efficient first move. They can help prioritize dental, ENT, or GI referrals based on the data you've collected. If you want hands-on demonstrations of the tongue scraping, gauze floss testing, safe saline gargles, and a sample way to keep the log, watch the hands-on demo we mentioned at the start. It walks through technique in safe, gentle detail and shows what to look for in real time. If after following the routines and documenting for 2 weeks the odor persists or you have any red flag symptoms, use the clinician scripts in the description to book the right appointment: dentist, ENT, PCP, or GI. Halitosis is common, often solvable, and rarely a sign of something urgently dangerous. But when specific red flags appear, or when a clearly documented pattern points to a non-oral source, timely evaluation helps you get the right care faster. You don't have to navigate this alone. Small, consistent steps, clear documentation, safe self-checks, and targeted referrals turn an embarrassing, frustrating symptom into a manageable clinical problem. If the stomach is contributing, the patterns you document are the key to getting a definitive evaluation. If the mouth or sinuses are responsible, addressing the specific reservoir brings measurable improvement. Take that 2-week log seriously, bring it to your clinician, and remember, the goal is not just to mask odor, but to identify and address the underlying cause in the safest, most efficient way. If you're ready for the next step, watch the hands-on demo now for step-by-step technique you can use in the bathroom safely. And if your breath remains unresolved after the 2-week plan, use the clinician scripts in the description to book the appropriate appointment.